Okay, thank you, Afreen. We'll be recording this video and we'll send all these videos to the participants as well after we are done with the meeting. So good evening, everyone. I know all of us are from different time zones, so it could be good morning, good evening, good afternoon, or maybe to someone good night. But thank you for staying awake and thank you for managing your time to be here with us. Welcome to the first quarterly event of the South and Central Asia CEE Innovation Hub, focusing on adolescent sexual and reproductive health. I am Prakriti Dakal, one of the founder of this Innovation Hub, and I'm so thrilled to be your moderator for this session. Along with me, we do have Afrin Noble as other founders, and we also do have members who are already here: Misbah, Sabur, Aisa, Pavel, Sehran. I want to see if they're already in a Zoom and they might be joining. I think some of them are still on the work. And then Gulnaz is also here. So we are here to discuss on very critical issue, the sexual and reproductive health for adolescents in emergency situation. And then through this CEE SRHR Innovation Hub, including different quarterly events, our goal is to bridge information gaps, empower adolescents, and enhance their ability to make informed decisions. So we hope together we're going to make this a fruitful and engaging session. So towards moving the session, I want to walk you through the entire event agenda. We start at 4:45, little waiting for a few friends, and we're going to end this session on 7:20. But we also have something after the session. If the participants are very keen and eager to introduce and have a networking session, we can create a breakout room towards the end of the session, and then you can unmute yourself and share your ideas, details, or introduce about yourself. And then we do have a remarks from IREX, our supporting partner, and then from Katie, who's going to introduce about the Innovation Hub. And not just that, she will be sharing about what is actually CEE, which is Community Engagement Exchange. We'll wait her to share more about that. And I would like to, again, extend my gratitude to US Department of State for being sponsor for the CEE SRHR Innovation Hub, and IREX, the implementing partner for that. And we will have throughout the session keynote remarks from our amazing and expert keynote speakers. I can already see them on a Zoom. And we'll have a panel discussion with practitioners. Then there will be a time for all the participants to get engaged in Q&A session with panelists. And if we got enough time, we'll see if we can address one or two questions from the participants to the keynote speakers as well. And we will have a closing remarks. Okay, and then we do have a ground rules for this event. I think it's been a while, all of us are on a Zoom setting like this after COVID. So I just want to remind all of you, let's go on a past and be like in the time when we were in COVID. So we will be respecting each other, treat all the participants and speakers with respect. We will do active listening, pay attention and avoid any kind of interruption. I could see someone just did something on the screen and that was disturbing it. So make sure that that will not happen again. We will be concerned about time. That includes me as a moderator and also all the speakers and also participants to limit the questions while asking to the panelist. And we know this is a very sensitive issue and the topic that we're trying to make it neutral. So we respect the privacy of shared information in this Zoom as well. And then make sure that the device is on a mute mode, just to maintain that we have done the setting that we need to unmute to the speaker head, just letting to the speakers known as well. Before your timing, we will ask you to unmute yourself and you can unmute and share your thoughts as well. And we will avoid using discriminatory language and behavior because we do speak in different languages, but our standard language we're going to use is English. So make sure that we do not accidentally use our mother tongue here and every one of us will be confused. Then we will also share you a feedback form that is so crucial for us to plan for upcoming events. So please provide us constructive and respectful feedback to us. So moving forward, this is what we already done, and we have kept the record of your responses. We were so excited to share that on our social media. So moving forward, there is something exciting as well that we checked in the applications participants, and we see what are the expectations from all of our participants, which is a roadmap for participants in SRHR education and advocacy. And we could see our participants really want to understand and get more insights and knowledge in SRHR. They want to get some practical strategies for emergencies. And some of them also wrote that empowerment through education. Hopefully, we'll be able to achieve that throughout our quarterly events. And professional development and networking. This is something that when we saw the response, like, oh, we want to do networking. So we thought of, okay, why not to create a breakout rooms at the end? So all of you can introduce and do the networking by yourself. And also, they want to learn, enhance their learning into awareness and advocacy. And throughout everything, through our amazing speakers, our participants who really want to get inspiration and motivation to be a change maker on this very important agenda of sexual reproductive health and rights. So moving forward, without doing any delay, I would like to hand over the time to our representative from IREX, also a person who is helping us to handle all this CEE Innovation Hub, Katie Sa, who is a program officer from Community Solution Programs, and also is looking for alumni affairs into CEE program IREX. Katie, over to you now. Thank you.
Thank you, Prakriti, and hello, everyone. Like Prakriti said, good morning, good evening, good afternoon, depending on where you are joining us from. My name is Katie Shaw, and I am a program officer working on the Community Engagement Exchange Program, or CEE, as we refer to it as, at IREX. I am based in Ohio in the United States, and so happy to be joining you. So CEE is a leadership development program that is sponsored by the U.S. Department of State's Bureau of Educational and Cultural Affairs, and IREX is the organization that implements this program. So CEE is a year-long leadership development program that equips young civil society leaders ages 21 to 28 with skills, expertise, and resources to develop multidimensional approaches to build healthy and engaged communities in over 100 countries throughout the world. In my work, I have the pleasure of supporting program alumni on many of our alumni engagement activities, including this Innovation Hub initiative. So CEE Innovation Hubs are regional working groups that provide alumni with the opportunity to collaborate and address shared regional challenges. The goal of these innovation hubs is to create regional communities of like-minded individuals working on similar issues within their own communities. Excuse me. So the CEE Innovation Hub responsible for this event is our South and Central Asia Hub focused on sexual and reproductive health and rights. And they are the first CEE Innovation Hub. And we are so happy to be supporting founders and members over the next several months to carry out initiatives like this one, and also implement in-person projects in their own communities, and continue to maintain virtual spaces for continued collaboration and conversation on promoting sexual reproductive health and rights for young people throughout their region. So on the CEE team, we greatly value the power of collaboration and believe that bringing community activists from diverse backgrounds together can really spark inspiration and creative methods for addressing community issues. Every time I have been in a space with CEE fellows and alumni, both virtually and in person, I've walked away inspired with new ideas and energy to continue doing this important community work that often can feel so challenging. So we are looking forward to the energy, expertise, and thoughts that you all will bring to our conversation today. And we hope that you'll continue to engage in this community that this Innovation Hub is building. So thank you for being here today. And we look forward to continuing to engage with you. Back over to you, Prakriti.
Thank you, Katie. And I should mention that thank you for being a huge, huge help in setting up this Innovation Hub and guiding us throughout the process. This feels like actually we're happening. It's happening now and with the first quarterly event, and we can expect how amazing it's going to be throughout the year. Thank you very much, Katie. So moving forward, we will now go towards the keynote addresses. Um, we're working. We'll give you the unmute option. So we were just working on this technical thing as well. If Afrin is there, can you please, there are two Prakritis, and can you pass the host to me? Just need to fix on the technical setup. So moving forward, we do have amazing keynote speakers with us. I am so excited to introduce them. Avni Amin and Sadie Bastian, who will be addressing more on WHO recommendations to adolescents on sexual reproductive health and rights. And we also do have a keynote speaker towards us after the first keynote session. So I would like to introduce our keynotes. Dr. Avni works at WHO Department of Sexual Reproductive Health and Rights with research, and she is a unit head for the rights and equality throughout the life course team. She focuses on violence against women and gender equality in sexual and reproductive health. She has a PhD in international health from Johns Hopkins University, a passionate and feminist scientist. And we have Sadie here. She is a scientist at WHO Department of Sexual and Reproductive Health and Rights and Research. She focuses on adolescent sexual and reproductive health, engaged in research for nearly 2 decades in Sub-Saharan Africa and South Asia. Our participants might be so excited to study more about your research papers as well. And her interest is in participatory methods and youth and community engagement. And we can see this is the reason that we have a speaker from WHO to make this more accessible to communities across the world. So over to both of our speakers, Avni and Sadie, and I'd like to ask the technical team to unmute both of our speakers.
Great. Thank you so much for this introduction, Prakriti. I will try to share screen and hopefully that will go okay. Just a moment, please, and I'll put it into presentation mode. Great. Does that look fine on your screen? Super.
Oh, there.
Is it okay?
Yeah, we can see. Thank you.
Oh, okay, super. So as with everyone else, I'd like to wish you a good afternoon, good morning, or good evening, depending on where you're joining from. And just very grateful thanks for the introduction to Avni and myself. As mentioned, I work as a scientist at the Department of Sexual and Reproductive Health in Geneva, where my focus is on adolescent sexual and reproductive health. Avni, would you like to unmute and introduce yourself before I move forward?
No, I think, Sherry, you should go when I speak. I'll just quickly introduce myself, but pleasure to be here and thank you very much for welcoming us in this forum. Over to you, Sherry.
Great, thank you, Avni. So our joint keynote today will focus on the WHO recommendations on adolescent sexual and reproductive health and how they can be used as a basis for advocacy to ensure the needs and rights of adolescents in emergencies are met. So in our brief session, our aim is to provide an overview on three main topics. We'll start off first with a global and regional overview on adolescent sexual and reproductive health. We'll then take a look at what is particularly important or unique about this topic and why it deserves increased attention and investment. Lastly, we'd like to share with you a few of the key WHO recommendations that can be used to inform your advocacy efforts. So let's take a brief look first at the rapidly changing global context, and I'd like to just highlight 4 trends or issues here. Firstly, there is an expanding population of adolescents globally, with more boys and young men than girls and young women. Adolescents are generally growing up in smaller households and in the context of increased life expectancy. Secondly, adolescents today face a world where the burden of illness is changing. For instance, the Lancet Commission has categorized countries into 3 different types: multiple burden countries, where communicable diseases, sexual and reproductive health related and nutrition related diseases predominate. South Asian countries largely fall into this category. Injury excess countries and NCD predominant countries. So although many countries still face the same health challenges that they did 25 years ago, it is undeniable that they're in addition facing new ones, such as overweight and obesity. The third issue to highlight is it's important to acknowledge the changing social context. Adolescents today, as you're aware, are more likely to be digitally connected, more likely to be enrolled in and complete school, but rates of un- and underemployment in young people are high, and with sex disparities. Fourthly, it's important to highlight that adolescents are growing up amidst multiple intersecting crises. For instance, climate change, conflict and emergencies, and as we have all experienced recently, pandemics such as COVID-19. So in terms of progress made or not made on the adolescent sexual and reproductive health agenda, as you'll see on this slide, the green text indicates progress, yellow means there's no stable trend, and red highlights unfinished business. So with respect to the progress made, we can say that girls and boys are more likely to initiate sexual activity later than they did in the past. Girls are less likely to be married and have children before the age of 18. They're more likely to use contraception and obtain maternal health care. Boys and girls are also less likely to have sex with a partner who they are not married to or living with, and more likely to use condoms. HIV incidence is declining slowly, but deaths among adolescents due to HIV have not. Now, turning to the yellow, there's no clear trends when it comes to unsafe abortion, mortality, and morbidity resulting from it. And finally, levels of STIs and intimate partner violence are high and growing. So let's take a very quick look at one concrete example. Here you can see a graph depicting trends in adolescent birth rates across the different regions. It's notable that South Asia has in fact made the most progress in reducing early childbearing, with the adolescent birth rate dropping from 49.6 births per 1,000 girls in 2010 to 29 births per 1,000 girls in 2021. That's the gray line I think you can see there on the graph. So this is an encouraging sign. It's a positive trajectory that is important to celebrate. But it's also important to identify what the barriers and opportunities are to making sustained progress on the adolescent sexual and reproductive health agenda. And this cartoon highlights just a few, including denial that adolescent sexuality is a thing, entrenched gender inequalities, resistance to meaningfully engaging young people, weak health and social systems, limited coordination across sectors, changes in population dynamics and family structures, and lastly, in line with the focus for this event, increases in humanitarian crises and emergencies. However, it's also important to have a glass half full perspective and systematically identify and capitalize on emerging opportunities. And here you can see a few as well, including the increased prominence of adolescents on the global, regional, and national agendas, increased investment in adolescent sexual and reproductive health, renewed commitments to universal health coverage, increased school enrollment, and advances in technology. So if we turn now to look more specifically at adolescent sexual and reproductive health and emergencies and the rationale for needing greater attention, investment, and advocacy, it's clear that there are a number of increased vulnerabilities that come into play, including the breakdown of basic health services as well as law and order. This can result in exacerbating barriers to sexual and reproductive health services, leading to lack of information and services, as well as stigma. Housing insecurity is another issue that is of concern, alongside disruption to schooling and education, resulting in many out-of-school youth. Of course, economic insecurity is a major concern. And in emergency settings, it may also mark a breakdown of social and cultural systems, which amplifies vulnerabilities. Additionally, there may be increased risks of gender-based violence, as well as increased potential for sexual and other risk behaviors, including substance abuse. Also, the onset of an emergency situation may mark the potential resurgence of harmful practices, including early marriage and trafficking. And finally, it's important not to underestimate the impact of personal traumas, including the loss of family members and other protection mechanisms. For these reasons and many more, adolescent sexual and reproductive health and emergencies is a topic that merits increased focus. So in the third part of the presentation, I'd now like to turn to the WHO recommendations. And due to time constraints, it won't be possible to cover all the recommendations in this document, but my colleague Avni and I will speak about 6 to provide a brief snapshot in the hopes that this will spark your interest to read the entire set of recommendations and take this forward in your own setting. So the purpose of this document is to serve as a user-friendly portal to the WHO guidelines and to inform advocacy, policy, and program design and research. Just to flag as well, there will be 2 WHO guideline updates this year that are relevant to mention. One on preventing child marriage and on increasing access and uptake of contraceptive use among adolescents, and one on female genital mutilation, which is an important issue facing adolescents, though not explicitly in the South Asian region. So let's now take a look at a few of the recommendations more concretely. So the first recommendation relates to comprehensive sexuality education, or CSE, which is a curriculum-based process of teaching and learning about the cognitive, emotional, physical, and social aspects of sexuality. It can be delivered both within and outside of the school settings. In emergencies, this might take the form of integrating sessions into mobile outreach or youth drop-in centers, or using other innovative approaches, including digital options such as mobile phones and the internet. CSE aims to equip adolescents with knowledge, skills, attitudes, and values to enable them to reach their full potential, skills to develop respectful social and sexual relationships, capacities to consider how their choices affect their own well-being and that of others, and also a general understanding of their rights throughout their lives. In many settings, there are several barriers to implementing CSE. For instance, as you can see on the cartoon, discomfort about adolescent sexuality and the misconception that the provision of CSE leads to early or risky sexual behavior, which the evidence does not support. So the second recommendation I'd like to touch on now relates to contraception, and there's 3 points to highlight here. First of all, early pregnancies, both intended and unintended, are an important problem. An estimated 12 million girls aged 15 to 19 and 2.5 million girls under the age of 16 in low and middle income countries give birth each year, and approximately half of those pregnancies are unintended. Pregnancy and childbirth complications are among the leading cause of death among girls aged 15 to 19 globally. So those are just a few statistics that really highlight the importance of promoting contraceptive use among adolescents. Secondly, promotion of correct and consistent contraceptive use has been shown to be effective in reducing unintended pregnancies and in turn reducing maternal and newborn mortality and morbidity. But it's important to emphasize that adolescents have diverse needs and preferences, and also that there are a number of different service delivery models to facilitate access to contraception. In emergency settings, considering which model is the most feasible will vary. For instance, whether contraception is integrated into whatever health services still exist, standalone clinics, mobile or other outreach services, or pharmacies. Whatever the service model, it should be free, confidential, adolescent responsive, and non-discriminatory. The third point relates to the importance of laws and policies in the provision of quality services. 14 million girls aged 15 to 19 have an unmet need for contraception. This is a huge gap, and it really highlights the important role that laws and policies have to play in addressing this. The next recommendation focuses on the provision of safe abortion care among adolescents. In the context of humanitarian settings and emergencies in particular, this is often an under-prioritized area for many reasons. For instance, it may be perceived as too complicated to provide, or that donors don't fund it, or that it is illegal in some contexts, or other reasons. But it's important. An estimated 5.7 million girls aged 15 to 19 undergo abortions every year in low and middle income countries, the majority of which are unsafe. And unsafe abortions have major health consequences. Adolescents, as we know, are more likely to seek abortions from untrained providers, to have a self-induced abortion, to terminate a pregnancy after the first trimester, and to delay seeking care for complications. They're also less likely to be informed about their rights. Safe abortion care, on the other hand, carries low health risks. Finally, abortion-related laws and policies in the provision of services is an area that really deserves increased attention. When safe abortion is legally allowed for adolescents, it is often not adolescent-friendly or tailored to their needs. So let's turn now to look at recommendations related to sexually transmitted infection prevention and care, or STIs. STIs among adolescents are another important issue that can have major health consequences, both in the short term and in the long term, ranging from discomfort and pain to infertility and other challenges. It's also important to highlight that adolescent girls have greater biological susceptibility due to the immaturity of the cervix, but also because of restrictive social norms, which hinder their ability to be prepared to have safe sex or to refuse unsafe or unwanted sex. Adolescent boys, on the other hand, are susceptible because of stereotypical masculinity norms. Third point is, in terms of prevention and management of STIs, effective approaches do exist to prevent, diagnose, treat, and in some cases, cure STIs. In emergency settings where health systems may be fragmented and where gender-based violence risks may be heightened, this is an area that needs increased attention. So the last recommendation I'll speak about before handing over to my colleague Avni relates to harmful traditional practices. Every year, about 12 million girls are married before the age of 18, highlighting the importance of this issue. In South Asia, levels of child marriage remain high at about 28%, and no region is on track to meet the SDG target of eliminating child marriage by 2030. This is a cause for concern given the serious health and social consequences of child marriage. However, as with other areas covered in the recommendations, it's important to point out that there is a growing evidence base for effective approaches, as well as those which are promising to tackle this issue. And finally, it's again important to emphasize the role of laws and policies and their implementation. Laws and policies forbidding harmful practices are in place in many countries, but it is often the case that the practices continue. So efforts must strengthen enforcement and must be combined with community mobilization, empowerment of girls, as well as the provision of health, social, and legal services to those in need. As mentioned earlier in my talk, in emergencies, there can be a resurgence of harmful practices, making this recommendation particularly salient for this session. So my colleague Avni will share with you the next recommendation related to intimate partner violence. Over to you, Avni.
Thank you, Sherry. And if I can ask you to just move the slides when I say next, please. So just building on what Sherry has presented, as Sherry said in one of her earlier slides, violence against girls and adolescent girls in particular remains an area of concern because what we've seen from data is that it's quite high, and the rates have largely remained unchanged. In 2021, WHO published a second round of global regional estimates on intimate partner violence and non-partner sexual violence. The first round of estimates on violence against women, that is on intimate partner violence and non-partner violence, were published in 2013. And what we see is that those rates between 2013 and 2021 remain largely unchanged. So in 2013, the estimate for adolescent girls age 15 to 24, so adolescent girls and young women, was 30%, 30, globally. What you see here is in the age group 15 to 19 and in the age group 20 to 24, and the dark red bar shows lifetime prevalence of physical and or sexual violence by an intimate partner. So already by the time the girls are 24, a large number, between 24 and 26% of these girls have experienced physical and or sexual violence by an intimate partner. And one thing to recognize that is that a lot of this is also happening in some parts of the world in context of early marriage, but not just. In some other parts, it's also happening in context of dating relationships between boys and girls. So what we are seeing is that this violence is starting early, and we know that the health consequences of this violence are quite stark. They range from increased risk of depression, increased risk of suicide, and for sexual and reproductive health, it includes increased risk of unintended pregnancies, induced abortion, acquiring STIs and HIV in some parts of the world. Also for pregnant women, it includes risks of preterm births and low birth weight babies. So this is those women and those adolescent girls, as well as young women who might be experiencing violence during pregnancy. Next slide, please. So WHO has recommendations for responding to violence against women for ages 15 and older, as well as we published in 2017 guidelines for adolescent and child sexual abuse. So here, these two documents on the left side that I have shown, one is the clinical guidelines from 2013 called Responding to Intimate Partner Violence and Sexual Violence Against Women for 15 and older. And then at the bottom is the clinical management of rape and intimate partner violence protocols for humanitarian settings. And the two documents are identical, except that the top one is more expansive, whereas the clinical management of rape and intimate partner violence for humanitarian settings has been adapted to prioritize those interventions and recommendations that are most applicable to emergency settings. So the first one gives you the whole gamut of things that could be recommended, and the bottom one is largely focused on prioritizing those that are applicable. And these interventions largely fall into 6 categories. The first is what we call survivor-centered or woman-centered care. And here the main recommendation is provision of first-line support, which is a minimum standard of care that everyone, including in primary health settings, should offer when survivors disclose violence. Then the second area is around identifying intimate partner violence, and WHO recommends something called clinical inquiry, or asking based on signs and symptoms, because we know that many health signs and symptoms that present to health providers, violence is an underlying cause. So to use those and use that as a basis for saying or probing, are you in a healthy relationship? The third set of recommendations are around clinical care for survivors of sexual assault or rape. And this includes offering emergency contraception, STI and HIV prophylaxis, as well as taking full medical history and doing a medical examination, or what is called a head-to-toe examination. The fourth is around training. And we know, from both survivors, adult survivors, but also from adolescent girls who have been raped, that health providers often either are not aware of what they're supposed to do or stigmatize them. And so the recommendations that WHO says is that they really should be trained not just in what is the appropriate response, but also in addressing the blaming, the victim shaming attitudes that healthcare providers might have, and to respond in an empathetic, non-judgmental way. The one area which is very, very contentious, particularly for adolescents, is that in many legal settings, at least for adults as well as for children and under 18, you have what is called mandatory reporting. So whenever violence, sexual violence or IPV, intimate partner violence, is reported to a healthcare provider, that a law says that they are obligated to report this to the police or to the child protection or appropriate authorities. Now, for adults, WHO says this is not appropriate because it violates the basic right to self-determination for survivors. For children, it's a little bit complicated because they are minors under 18. And so there are a bunch of what we call more nuanced guidance around under what circumstances reporting should be done, keeping in mind, particularly for adolescents, a balance not only of their need for protection, but also their right to make autonomous decisions in line with evolving capacities. Next. So very specific recommendations for adolescents, which are in the child and adolescent sexual abuse guidelines and child maltreatment guidelines, are really for the need to have adolescent-centered, gender-sensitive first-line support to make sure that additional trauma and distress that maybe under 18 might experience while going through a medical examination and asking about history of what happened is really minimized. And we also, for adolescents, recommend HPV vaccination if adolescents are not already vaccinated. And then for mental health, if there is support and specialized mental health services, to offer CBT or cognitive behavioral therapy with trauma focus. Next slide, please. So just flagging that some of these legal barriers are there, where mandatory reporting poses a lot of barriers for adolescents, and particularly adolescent girls, to report. If they are pregnant, for example, as a result of rape, they might automatically be reported to the relevant authorities, and that prevents them from accessing services. We know in many settings there are statutory rape laws. So if a minor is around 14 or 15, and even if she's had consensual sex with her boyfriend, it might get reported as rape, and that may prevent her from accessing sexual and reproductive health services. And of course, as Sherry said, abortion is an issue. So if a minor is seeking abortion because of rape, because of restrictions in abortion access, and particularly there may be parental consent requirements or caregiver consent requirements, this will also pose an additional barrier for post-rape care access to adolescent girls. So what we do recommend is that for reporting, it's important for the providers to assess the health and the safety and the well-being of the adolescents and what would happen to them as a result of reporting to the police or relevant authorities, and to make sure that no matter what, the adolescents' immediate medical needs, as well as first-line support, that is psychological or psychosocial support, is prioritized over reporting, so that before things are reported, the adolescents get the minimum care, healthcare and psychological support in response to violence. We do say that actions that are not in line with human rights standards, unless of course there is a risk of suicide or risk of safety of the adolescent client, is where there is consensual sex between adolescents, and that shouldn't be reported. Or if the adolescent, and in line with evolving capacity of the adolescent to make certain decisions as they mature, and they, for whatever reason, don't want the parents to be involved, to respect their wishes. So that's it from my side on the violence recommendations. As Sherry mentioned, this is really a snapshot of a much larger body of work that has and recommendations around adolescent sexual and reproductive health. Over.
Thank you, Avni. So to
Back
wrap
to you.
up,
Yeah.
Thank you so much. To wrap up, I'd like to leave you all with 8 key take-home messages focused on an agenda for action to ensure nobody is left behind. The first is the need to highlight at every opportunity the changes in adolescent lives in your communities that are brought about by inequalities, urbanization, climate change, and humanitarian crises. Secondly, advocate for a multi-sectoral approach and to address the underlying causes of poor adolescent sexual and reproductive health outcomes. This is urgently needed to accelerate action. Thirdly, we urge you to work with your governments and communities to insist on evidence-informed programs tailored to the local context. Fourthly, ask for laws and policies that respect adolescent rights and protect them from harm. The fifth point is to advocate for age and sex disaggregated data analyses to uncover which groups of adolescents are being left behind and to inform programs and policies and track progress on key indicators. The next point relates to the need to conduct, support, and advocate for implementation research, which addresses how to deliver proven interventions tailored to context at scale with quality and equity. The seventh point on the agenda is to demand for meaningful youth participation in efforts to address adolescent sexual and reproductive health. Youth advocacy is key. Lastly and finally, bring to the table innovations, be it social or digital, to address adolescents' access to sexual and reproductive health. So on behalf of Avni and myself, I'd like to thank the organizers for inviting us, and to all of you for joining this session. I really hope it will be useful for your advocacy efforts. And on this slide, you can find the main references for our presentation. Over to you, Prakriti.
Thank you, Sadie and Avni. Thank you for such an amazing, enlightening presentation. WHO's recommendations are really very vital in advocating for and meeting the needs of adolescents in emergencies. And then, as you clearly mentioned, that this is just the start, and having both of you here and sharing this key information is really vital for us to plan our advocacy efforts ahead. I have to mention that all the participants here are youth. Around the average age of all the participants is like 23, 24. So we are on a right place to learn from amazing speaker like you. And connecting to your speech, I have a poll that is dedicated to all the participants to go into the future, and it is like a SRHR time capsule. So I'm going to launch a poll with thanking both of the speakers. Check if there is a poll. If you were creating a time capsule for SRHR to be open in 50 years, just imagine what one item would you include to represent today's effort. That can also include, as Sadie and Avni mentioned, that advancement in technology, a digital process, or current policy document that can be still reused in 50 years, or a symbol of current advocacy efforts, especially through youth. So we want to know from your side. We're going to see the voting, and let's see which one wins the more. Will be, a landmark or something that we can keep protective to showcase in 50 years. So we're getting votes. I will be in 15 seconds. I will end the poll, and we will see the result of it as well, which is very exciting to imagine what will happen in 50 years as a time capsule for SRHR. So 45% of participants have participated. I'll be waiting a few seconds to give chance to all the participants to navigate through the Zoom and to vote for the polls. We have 101 participants here. I encourage all of you, including us, organizing team and everyone, also maybe including speakers as well. If you want to participate, just vote one of the options available. You can only choose one of that, which is very critical because this is one of the options we have to do as a decision. So 58 participants have already participated. We'll wait for a few more seconds to get the majority of our participants participating on this poll. Uh, 63 of them voted. We'll be still waiting a few more. Okay. Okay, I'm gonna end the poll in 5 seconds. So be rapid. 1, 2, 3, 4, and 5. So this is a result of the poll. Can you see in the screen? So piece of technology used in SRHR is 35%, and the winning option is a symbol of current advocacy effort. So I think we'll be able to create something amazing story of advocacy and pass on to the future generation as well. Thank you, everyone, for your active participation. And we would like to move forward. Again, thanking to our two keynote speakers, Avni and Seri, for your time, dedication, and for preparing such an amazing presentation for here. So moving forward, we would like to introduce our another keynote speaker who is already here, I guess. We'll ask the technical team to give the audio access to them. So we do have another keynote speaker, Kunle Etini, who is a UNFPA representative to Sri Lanka and Maldives. His experiences in sexual reproductive health and rights, human rights, public health, and also in law. He has served in Nigeria's National Agency for the Control of HIV and AIDS, NACA, and he's also the alumni of Johns Hopkins Center for Communication Program. I can see the speakers being alumni of same institution as well. So excited to have your presence, Mr. Kunle, over here. So if you are here, I would like to give the floor to you. Thank you. Thank you for your presence.
Thank you so much for, I hope you can hear me.
Yes.
Do you hear me? Okay,
Yes.
I see that. Thank you so much, Kaza. Thank you for having me join you today. I think I appreciate the opportunity to speak to such a diverse group of people, over 100 people online, and to talk about adolescent sexual and reproductive health. Today's theme, I've been asked to discuss adolescent sexual and reproductive health in emergencies and disasters, and the importance of that. It's important to start by understanding that at the United Nations, I am the country representative for UNFPA in Sri Lanka. I cover Maldives, and I used to work in the Gambia as well as representative. I've done quite some work in this area, and I seriously believe that ASRH is probably one of the most important areas that we could work that will have a telling effect on our population and the development of our people and world. As the world continues to face multiple crises that severely affect the health and well-being of the generation, we are reminded that in emergencies and humanitarian or conflict settings, the risk of sexual and reproductive health rights violation is exacerbated. We live in a very chaotic world, and I was speaking to some people earlier today and said 2024 is probably going to be one of the most chaotic times in recent time. We woke up this morning to news that Yemen was being bombed. We know what is going on in Gaza. Every region of the world is facing some conflict or the other. But we also know that in conflict settings, women, young people, girls are probably some of the most vulnerable in those times. And even as we begin to look at issues that affect them at that time, sexual and reproductive health becomes one of the most left behind facets of their life. And I know the speaker before me, and I thank my colleagues from WHO for really expanding on those issues. In times of crisis, we often only focus on immediate needs, food, shelter, and a broader healthcare. That, if not particularly addressed, might leave young people's sexual and reproductive health behind. Adolescence is a critical phase of life that is marked by physical, emotional, and psychological changes. When emergencies strike, young people and adolescents are particularly vulnerable due to their already limited access to sexual and reproductive health. Again, the speakers before me really discussed culture, norms that already that serve as barriers to young people accessing SRHR. The consequence of this neglected need is far-reaching and long-lasting. I'll give you an example. In South Asia, where we have about 350 million young adolescents, and even it's over 60% of the world's young people live in this area of the world, about 750 million people. We know that we already grapple with challenges of sexual and reproductive health. In Sri Lanka, young people make up 23% of the population. And young people are reported to be affected by crises that we currently are addressing. In 2022, Sri Lanka went into pseudo-bankruptcy, for example, and it's a form of emergency. And in that time, we have been working to see how this affects young people. I can clearly say that young people's sexual and reproductive health were, critically affected. And a recent study actually showed that this crisis is preventing young people from existing vulnerabilities. In Sri Lanka, for example, about 1,000 abortions are practiced, take place every day. Now, the law of the country does not even allow abortion. But we also know that teenage pregnancy is on the rise, again, because of limited access in times of emergencies that we have. And we know that this has also led to increased school dropouts and considerable violations of rights. I must quickly say that the traditional emergencies that we used to have has really changed. Now countries and nations really flow between major emergencies to times of building resilience. So, for example, an economic crisis would hitherto not be taken as an emergency. But the question is that these kind of crises have all the hallmarks of what we used to address in major emergencies. People are dying, gender-based violence increases, school dropouts, education stops, access to health services is hindered, and all those. Let me just quickly make a little dive into disasters and conflict that affect young people. We know that their mental health, is severely affected. Oftentimes, adolescents have not even graduated to a position where, they can individually support themselves. And the consequences of failing to address these areas impairs the adulthood and physical and mental health. We know that disruption in food systems, many young people who are adolescents are already fending for themselves, but also they do not have those access to communal support or communal structures, social systems that support them. Health systems could be overwhelmed. We know that in South Asia, there's a major challenge of young people accessing sexual and reproductive health service, even in times of quote unquote stability. For issues that we all know, culture and norms like I've spoken about, and these complications really exacerbated. We know that contraceptive access is already difficult. We know that emergency contraception doesn't exist for many, and we know that increases in unintended pregnancies, sexually transmitted infection, but also violence. In Sri Lanka, we have seen almost 100% increase in violence against younger people, children and adolescents since 2022. And these are issues that really need to be addressed. Disruption in education systems. And I'm trying to bring together the intersectionality of emergencies and how it happens. When education systems are disrupted, the school system, which either could be a safe point for young people and adolescents, it's taken away from them. So oftentimes they spend more time at home, on the streets, and it really exposes them. Also, some young people are able to access some form of adolescent sexual reproductive information, if not services, in school. And that is also taken away from them. So that, like I said, increases the risk of violence, exploitation, early marriage in some communities when there is no money. Just to make it simple, people basically give depending on the economic situation. They tend to marry their kids, a little earlier than they would have done. And that removes the dignity and autonomy of the adolescent, but also exacerbates the potential of violence. So to address these challenges, I've been told to speak about the experience of this around the world, and I just wanted to set the stage about the way some of these things happen. It is important to continue to implement key strategies. I do not want to be repetitive from the speakers before me, but it's important to strengthen healthcare systems that are responsive to young people. It is key. We are beginning to see that efforts to single-handedly or to address ASRH, different in emergencies, oftentimes suffer from lack of integration into major continuous health systems. So it's important to strengthen health system. How do I speak about strengthening health system? The sexual and reproductive healthcare services must be available to young people and adolescents. That is not the case in most of our communities and countries in South Asia. And you can take it from Nepal to Sri Lanka. There are many barriers. Even the healthcare worker is not sensitized enough to provide non-judgmental services to young people. And to do that, we must make the quality and important. And I'll go to policies later. In crisis situation, when things are unexpected, it is not very likely that the system will respond in a way that looks after young people. And I'll speak to issues around, for example, we need to strengthen our conversation of ASRH in the Interagency Standing Committee that addresses humanitarian issues. Important to continue to strengthen that factor. It works there, and on this area, we, the UN agencies and others, can do more in those conversations that cuts across not only healthcare, but education. We must create safe spaces and support networks for young adolescents to belong to, which is essential. And I'll give you examples of where we've done this, working in safe spaces, exactly, not necessarily creating or duplicating. I have seen in my work, for example, in the Gambia, that there are already spaces that we could invest in to support young people. For example, in communal interventions, you will find that young people already have their platform whereby they talk to themselves, they believe in themselves, they engage. We can invest more in those platforms and to see how we can provide information and services through those platforms. I'll give you an example. UNFPA is working with national youth organizations to establish the Youth Peer Network. Many of us are familiar with YPeer. YPeer does fantastic work. Even in Kazakhstan, I was in Kazakhstan last year, and I saw the excellent work that YPeer does on the global YPeer network on providing young people with information. Now, this really does a lot of out-of-school training for young people. I would come to comprehensive sexuality education, but we know that the school curriculums are probably not the most effective ways, or at the moment in the global South, to reach young people with quality information and education on their sexuality and sexual reproductive health. For many reasons, it's culture, it's the barriers that they have created. But working with youth networks and providing youth leadership, we do a lot in this area. We need to continue to work to engage with local communities and promoting community-based responses. Communities understand themselves, they really know what they want. And I believe every community wants the best outcome for the young people. Oftentimes we speak in languages that these people do not understand. We must introduce flexibility into our work and our conversations in communities. We must understand the values of communities. We must really try to seek and to find that meeting point of understanding. healthcare, as WHO would say, is a major undertaking, and the people are the most responsible for their healthcare. And we cannot, be more responsible than the individual or play the piper in this case. So until we can continue to work with local communities to find an understanding, and there's been a lot of success stories in that area. When you look at vaccination, for example, of course, I will skip the time of COVID and all that. But when you look at vaccination in the global south, we saw the increasing trend of conversation and community engagement, and now it changed that for sustainable and context-specific development. So the United Nations and the humanitarian agencies must continue to work in this place to build the resilience of these communities even before emergencies come. And in this way, we can provide practical support, but also to understand that equality is key in the conversation. Gender equality, the empowerment of women must be central to this work. And again, addressing sexual and reproductive health of adolescents in emergencies would always be collective. Governments, NGOs must collaborate. And I want to share a few of the stories that happened. I spoke about Gambia earlier, and I'm very proud about the work we did by working with communities to actually support women to establish forums where they are the one giving that education to their young people. But so mothers, they're playing the role of the educators. Anyone who knows the Global South knows that SRH is not a conversation that really happens between mothers and children. And I ask myself, how do we expect for parents to be comfortable for me or another person to have conversations that they cannot have conversations with their kids? So how is that going to work? So I felt like we felt that it was important to work with those family systems and values, and for them to understand that this is where these decisions that they might be willing to make will lead for their children. And what did we see? Even though there was a practice at that time, there was a massive change of government. In these communities in 17 districts, there was no increase in adolescent pregnancies. There was child marriage went down, female genital mutilation, that it was in 76% in Gambia as at 2013, reduced from that community, that district, by about 30%. And this was a 4-year work and program that we worked on. So even the major duty bearers, that role to play and supporting them to do it might have more catalytic effect than for us playing it ourselves. In Sri Lanka, we have, in the last 2 years, we've delivered critical support to the systems. We're training young people. We continue to provide young people with the ability and the capacities to, or to support their capacities to respond to their own needs. Creating trust between communities is also a very difficult challenge. I spoke about the health systems earlier. It's important for the health system to seek to be responsive. And I in this area, we might have, because the healthcare provider also comes from the community. We cannot assume, and I really choose to take this conversation from the socio-ecological perspective, right? Health is not, this is a social issue, and the healthcare provider, oftentimes I have seen where the healthcare provider has been a barrier. At some point, when female genital mutilation was banned in the Gambia by a prescription of law, the women who were cutting, stopped cutting, and the cutting shifted to the circumciser in the health facility. So nurses were the one practicing female genital mutilation because laws are not norms. Laws are not norms. Laws are not social, societal norms. And if a society does not support the laws that are made, the idea of that law having any impact is very limited. Because even the judge, the policeman who is supposed to carry out the arrest and all that, they would not do anything. So these are the things that we must really, and I choose to not take a scientific approach here, but to also speak about those cultural and values, and to basically continue to work with those communities. And I've seen it work, and I've seen it happen. I really believe that we must empower young people to take the lead. And I spoke about that in their health. It's a generation that is well sensitized. It's a generation that know more than we could ever imagine. Indeed, I understand that most parents choose to look away from what their kids know. However, if they do not have the right information, they might not make the right decisions for their health. And I'm no longer a youth, but I was once there, and I knew that my mother never had any conversation with me on my sexual health or anything, and even as I went to the world. And that's a lot for myself. I come from a family of all men now, eight children, and none of us ever received any information from home or from the system. So that is what I see. But my knowledge started by working accidentally into a youth space where youth leadership was happening, where knowledge and information was being shared informally. Indeed, it started like an academic process. We're there to rehearse for school. But because we have seen how this works and how young people can trust themselves, there has never been so much division in the world than it's now. Young people are completely divided by demographic, millennials, Gen Z, and there's seemingly no conversation between this generation. I don't know what I belong to now, but I understand that I'm very far behind in the knowledge of young people. Again, I cannot assume that I know it. It's important to close that gap in conversations and provide access to young people where they are and creating that space to support them. I strongly say young people are organizing themselves. They're having youth camps. How can we use these opportunities to let them lead, let them define what they want? And in Sri Lanka, we're currently designing a process where the young people of this country says, this is the Sri Lanka we want. And the Sri Lanka we want speaks across four things. It's about governance, it's about rights, it's about opportunities and jobs, and it's about their health and welfare. Understanding that these issues are interconnected to deliver on their potential. I must reverse here a little to say, in the end for us, the more determining factor is that every young person should achieve the fullest of their potential. And SRH is a component of that, and that's why it's key. So we must continue to advocate around health and rights to do this, especially in emergency setting. In the Gambia, like I said, we use the existing radio platform. Young people will be able to do that, and we continue to invest in this area. It's important to understand that ASRH, again, does not stand alone. What are the interest points for young people? Every day you see a youth lab. What is a youth hall? There's technology, there's society. Young people want to be creative. But it's important, how can we engineer their creativity along ASRH? It's also important to think about this kind of thing, whereby we find a way of amalgamating their interests that deliver the best youth for young people. And we've seen, major youth champions, youth entrepreneurs doing great things in these areas. And we can even, work with them to create things that address the development, humanitarian, and peace nexus, which is also very, very important. And ASRH stands at the middle of this. We spoke about innovation, and that's what I feel like it's key, and digitalization. Sometimes I wonder if we are not paying too much attention to the quote-unquote traditional school system. There have been millions of dollars and decades invested into comprehensive sexuality education in school. It has become a major political tool and conversation. It has affected elections and all that. And I see that even if it went on social media now, it's about what kids are being taught in school. It's all changing. We don't know the truth. We cannot decipher depending on where the algorithm sets you. When you click the first time, you just continue to be fed different things. But the question then, begins, and I worked in Ghana at a time where we were launching a transformative comprehensive sexuality education curriculum across the schools. And a day before this was launched, a religious leader took to the airwaves and he ended it. The president, the prime minister had all supported this process, but they had to reverse course because it was going to affect them in elections, it was going to affect their popularity. Now, when I continue to speak as I've done, and we're working on the CSA framework in Sri Lanka as I speak, the question I ask is that, is this guy going to put his political future in line for me or for my issue at this point? That's a question that is yet to be answered. But the question is that we already have places like digital tools that young people have circumvented, for the want of another word, the access barrier that's created by schools, by teachers, and it is digital tools. The digital school during COVID in this country where I work really took kids to school, and people learned a lot from digital school. The digital penetration, for example, in Sri Lanka is over 70%. But the question is, how can we use this to provide access and information to young people? And it's important to continue to work in that area. Now we must continue to work with leaders, and I'm sorry, just I'm rounding up. You know, we must continue to work with our leadership to ensure that we do more in this area. Policies. I'm also happy to discuss policy. It's important to understand that ultimately we need the right policy environment. We cannot continue to flirt around the way we're doing this. And we must also be flexible, like I said, in our response. So for example, we know that sometimes the word sexuality is the issue for access. You know, what if we called it health? Does it change anything? You know, does it call, if we said adolescent health and we make it clear that this is so that young people can access the right information and services. I have seen in many countries that what the countries say in New York is completely different from what happens in the country. Sometimes the conversation at global platform is completely for political reasons. Every country wants the progress of its young people, understanding that this is key to their national development. And I will centralize it on the demographic dividend framework. If we're speaking to policymakers, to let them understand that most of the countries in our region are worried about declining fertility, which might result in declining population. But it's important for them to reap a demographic dividend, and our window is rapidly closing. So the question is, how can we centralize our advocacy on the fact that we're not only speaking of ASRH, but understanding that the youth governance, and I'm going to end in a bit, youth governance is key. Improving labor and productivity of young people is very important for national development. And there is no way this can happen without right investments in ASRH. Because if you lose your young people to teenage pregnancy and they drop out of school and there is no way to come back, it becomes a difficulty in meeting national objective. For us, that is the center of how we work. That is what we do. We really believe the access to sexual and reproductive for adolescents, including contraception, is fundamental for national development. And it's central to our advocacy. And we're building knowledge and evidence. I picked this from the discussion by my colleagues from WHO earlier. It is key to national development. It must focus on how countries work to respond, and it must be evidence-based. It is my understanding that if we are able to do this, our response in humanitarian setting will be better because we already have the framework for working in those settings, and we can rapidly deploy. I apologize if I took more time than allocated. I'm not sure I'm not timing myself, but thank you so much for listening to me. Over to you.
Thank you, Kunle. I can understand this is a huge passion area for you, and would love to hear you more, hopefully in upcoming session as well. And thank you for proudly sharing the success story. That is something all of us need to set an example in each of our countries. The collective approach in Gambia, Sri Lanka, and this different communal structure, like a community system, plays a very huge role in this. Thank you for being here, and your valuable presence means a lot to all of us to learn and grow. So connecting to Kunle keynote speech, we have something as a poll that we want all the participants to participate, but make it quick. This poll will be open just for a few seconds, and then we are super excited to go into the panel discussion. So The poll is about, you need to rank order poll is like rank the following challenges in order to of importance when addressing adolescents in SRHR emergency. So as Kunle mentioned, there are several challenges and we just want to know your perspective towards these challenges and where you think that the ranking is on. So it's on your screen. I hope all of you are here, not sleeping. This is also checking that our participants are very active and then participating on a poll. We'll be opening this poll for a few seconds and then we'll be moving towards our panel discussion. I can see all the panelists, Sila, Novel, and Veena already here with such a smiling face. Excited to welcome you all. And then I could see the participants actively participating on the poll. This will help us to even get the frame and then structure of the different communities because the priority could be different for Nepal. For Nepal, it's mostly like, from my perspective, culture and social barriers, access to education, and then for other countries or other communities could be different. So thank you for participating there. I'm checking time as well and excited to go to the panelist speaker as well. So 5 seconds more, please be quick, all the participants. I'm going to end the poll shortly. Okay, here is the result. This is the different hierarchy set by our participants to rank the challenges of SRHR and then especially in terms of emergencies. Thank you everyone for your active participation. Now we'd like to move towards our panel discussion and would like to introduce our panelist speaker over here. So we do have a panelist speaker, Dr. Veena Shrestha. She's from Nepal. She has over 12 years of experience in clinical management of reproductive health and family planning. She is also a director at the Family Planning Association of Nepal, FPAN, as a program director. She's involved in developing sexual and reproductive health guidelines, and I have an honor to get an opportunity to work with Dr. Veena previously and get to know a lot about her. And I hope this opportunity will also open space for other youths across the world, mostly from Nepal, to get connected with Dr. Veena. Thank you, Dr. Veena, for being here. And we do have Dr. Novel here as a panelist speaker and also the founder of CEE SRHR Innovation Hub. He is also the public health practitioner with a focus on emergency and disaster context. He has his roles in government and international organization and different settings and different positions working on it. He is pursuing a doctoral program in global health leadership at the University of Washington as well. Dr. Noble mentored the first cohort of Hamro Bahini. I can see a lot of Hamro Bahini champions here as well, and we'll get to know the stories of Hamro Bahini through Novel as well, who is already here. And we have another panelist speaker, I would say a youth activist. I know a lot of us can resonate more with Sila. Our average age of participants is also like 24 or 25. So welcoming you here is a representative of all of us. Sila is SRHR activist from Karachi, Pakistan. She focuses on adolescents, SRHR, menstrual health, and SRHR in climate context. She's the one working in grassroots communities for reproductive justice. So glad to have all three of you over here. And I want a technical team to spotlight all the panelist speaker here, and then I can ask all the participants who are already here. Feel free to share if you have any questions or anything you want to address to panelists. And then if there is anything you want to especially ask to the keynote speaker as well, we'll try to get responses from them over emails as well in upcoming days. Okay. Ready to go. I am checking the time, 6:14. So we'll be a little ahead than the time, but we'll make sure that we'll get it done in time. So I would like to start the panel questions, maybe starting from Dr. Novel, who is super excited, and it's early morning for him as well there. I have collected all the questions from the participants. So as a responsibilities of moderator, I shortlisted the questions and tried to rearrange it in a way that would be easier to communicate with the speakers as well. So starting from Dr. Noville, would like to add that what role can young individuals play in contributing to and participating in SRHR initiative, particularly in crisis response efforts? We have heard a lot from our keynote speakers, mostly the global perspective. And we want to hear from you based on your experience and more towards the local perspective as well. Over to you, Noville. Yeah, and also, Noville, I know you have sent me a video to play here. So let me know, when do you want me to share the video? So I'm ready to play the video as well. Over to you.
Yes, thank you. Thank you so much, Prakriti. Let's try to go back to some disaster scenarios and think about what we are talking about today. Imagine that it's the aftermath of an earthquake. A health system is struggling to coordinate sexual and reproductive health issues. Also, let's think about a cyclone that has affected one of our countries in the region. And, a person has been subjected to sexual assault, gender-based violence, and this person is in urgent need of survivor services. Also think about the situation where a flood has affected a country and STI or sexually transmitted infections are spreading, but the contraceptions are not available. Think about a conflict, which is very common every time we switch on the TV or the radio or browse the social media, we hear about conflict. So in this kind of a conflict situation, a mother that is close to delivery is challenged with having safe delivery facilities. Think about a tsunami. After a couple of days following a tsunami in a relief camp, unwanted pregnancy happens because we don't have family planning services. Think about a situation where a country or health system is trying to get back to the normalcy after disaster. So these few scenarios that I just described to you shows us different challenges that we face in the aftermath of disasters, irrespective of the cause of the disaster, whether it could be due to a natural hazard or due to a man-made situation or due to a complex emergency. These issues, the coordination challenges, sexual and gender-based violence, spread of STI and HIV, challenges in delivering of safe mother and child health services, unintended pregnancies, and lack of moving into comprehensive sexual and reproductive health services are common phenomenon. Over and over disaster, there's ton of evidence which show that these 6 issues challenge the provision of sexual and reproductive health services in the aftermath of a disaster. Now, what do youth and adolescents have to do with them? They can help in many ways to address these issues, in addition to the government, non-governmental health organizations, UN agencies, community organizations, etc. So they can be active stakeholders in addressing these issues. For example, youth committees could support the coordination of sexual and reproductive health services in an emergency as a part of the broad coordination mechanism. Let's take about gender-based violence in a disaster situation. Youth support networks can help a survivor in accessing the services. Youth can play a key role in promoting sexuality education, focusing on prevention of STI and HIV in disasters. Take it about safe childbirth, adolescents and youth can advocate for the services as well as in spreading awareness in the community. And also they can contribute to promoting reach for family planning and contraception services. And youth can play, as Kunle very clearly mentioned, as well as the other speakers mentioned earlier, in advocacy for sexual and reproductive health services, including comprehensive SRH services. So these 6 challenges, 6 solutions, and youth can be very clearly matched, and there is a definite role that youth can play in disasters, emergencies, and crises that our region as well as the world is facing. And that is the focus of this particular symposium of our first quarterly meeting, where we want to mobilize and prepare the youth of our region to play a more active role in such conflicts, challenges, and disasters. Over to you, Prakriti.
Thank you, Dr. Noble, for rightly mentioning the solutions and the area, and also setting up the tone of the emergencies and crisis. So when we think about the disaster, for us, for Nepalese people, we tend to think, oh, it could be the earthquake or a huge flood. That is two things that is, hampering a lot on us. Moving forward, I would like to go towards Dr. Beena. I hope she's here. Hi. As an expert in clinical management of reproductive health and family planning, we want to know that what inspired you to focus on adolescents, sexual and reproductive health, and how has this field been evolved, especially in a context of Nepal? And during the process, what are the current challenges in providing access to SRHR, like Noble mentioned, give the different context of SRHR, particularly the context of SRHR during emergency in Nepal. Over to you, Dr. Beena.
Thank you, Prakriti, for this opportunity to speak in this platform. Well, namaste, everyone. Good evening from Nepal. I will stick with the Nepal context, as I'm representing Nepal here. And the country like Nepal, we are from a developing country, and we are, I think, within the top 15 countries where the disaster is quite prone countries. So disaster prone countries. So recently, we are also actively supporting the SRH services, comprehensive SRH services in the Jajarkot and Rukum West, because a month, 2.5 months back, we had a massive earthquake. So earthquake, flood, this is a part of our country's issues is that every year we are facing. So yes, adolescent and youth is the main area where we really need to invest. Everything only one organization cannot do. Everybody needs to come across and invest on the youth. And we should not be waiting only for during the disaster time. We have to, like PAN is the organization which introduced the CSC with the support from Danida in 2007-8. From that time onwards, we were doing regularly, continuously advocacy. And at the, I think 2015-16, we were successful to bring the CSC in the National Education Sector Plan of 10 years. So like this way, but still we are struggling to make it in the school curriculum, regular subject, as a regular subject. This should not be like a, and this education is a is wise. There is a education system is there on the sexual and reproductive health, which we all believe that we must make sure that every individual, every student must know about their sexual and reproductive health. And yes, and the thing is, like, in the disaster prone, they are the most vulnerable people, and we have to have a support from the local leaders. And in every program, every thing, we should not be only directing towards the female. It should be both. Male engagement is very much important, because even though we say that we have a empowered women and all, but still we have the decision makers are male. Male support is quite, I mean, hard in the community than when the females speak. So this context also we should not be have to think from that angle also. Here in the disaster areas, we are trying to ensure that every adolescent and youth will be, I mean, they are in the tent setup also. We are providing a education, comprehensive sexuality education to them. Yes, right now is our colleague also just spoke about the gender-based violence. They are very much prone on GBV. We are providing the GBV counseling, and we have been developing a network to address those, and connecting them with the one-stop crisis management center. So these are the key areas which we really need to bring in wherever the disaster comes. Yes, those areas where teenage pregnancy, our colleagues have spoken, STI, and other general issues. And the female are the not only the young adolescent, all female, their health issues is being not given that importance. So sometimes we have to design the program taking the service near to the mm, uh, female or the community they need. So we have to design the program where we have to put the people in the center, and put our all effort, so that how we can bring them in a sexual and reproductive health services areas. So that is why the adolescents and youth, and the thing is like not only in the crisis area, we have to uh, include the peri-urban and urban. Most of the funding are going towards the far rural areas, where equally, yes, we do agree that those areas also need to give a priority. But country like ours, where migrant workers are huge number, around 11% migrant worker are contributing in CPR. So that is why like the even like from the rural they come into the peri-urban, from peri-urban to urban, urban to another country. So migrant workers is there. So if not only migrant workers, and the main the thing that people are migrating is to support their family, so that their children will get the better education. But that is why they will come to the urban peri-urban areas, and for the education, where our focus should be reaching to those adolescent and youth who are really vulnerable, because they are in a one room or in a hostel for the further studies, and they have a very raw experience with the external environment, easily get carried away from the anyone. So, and they can be the voice for their own village, own community. Once if we can make them from the education point of view, from the importance of SRS, they can be the uh, peer educator. They can be the educator for the community back in their own village. So from that angle also, we have to invest on adolescent and youth. Even though our marriage age is 20, but we find lots of adolescent and young people already in a relationship and married also, and getting a teenage pregnancy. So those areas is really much needed to give attention. In crisis situation, they are reluctant to come to the service site for the services. So we might need to take the services at the home based pattern, or the where they want to, or and that in case of the technology, everywhere internet access is not there everywhere. I mean, we have a very much in poverty area, people do not have a smartphone. So the investment digitalization of the education is also there. But those people who are deprived of internet or the smartphone or the telephone itself, simple phone also they do not have. So we have to think from that angle also. So all the programs which we develop where we are, what type of community we are with. We have to consider that, and considering them, we have to design the program. So here we are taking most of the in the disaster prone ward, one ward we are doing 1 day service, and we are moving to the another ward so that the uh, they can get the services near to their community. So this is
Yeah, Dr.
the
Veena,
way that happens. Yeah.
Yeah, thank you for really addressing the situation like home-based practices to especially during crisis and emergency. I think that is something that we really need to advocate more about because they are adolescents usually feel reluctant. So connecting to your answer, I want to move towards Sila. As I already mentioned, as an activist who has worked in this area extensively on challenging societal norms and stigma, but I'm so sure it's not, Pakistan is not anywhere different than Nepal or Sri Lanka in terms of taboos or stigma. So can you share your insights on how the societal stigma plays a role into adolescent sexual reproductive health and services in Pakistan, and especially you are engaged into different initiatives with Baitak and also a book which is about Nisa Kahaniya or something. So do you want to add a little about what is that and also share how the societal taboos are affecting it? Thank you. Hello, Sila, we can't hear you. Hello? Hello?
Hello, can you hear me now?
Yeah. Yes.
Okay. So hi everyone, and thank you Prakriti for such a lovely introduction. And I'm also really happy to be like a youth representative here, like on this panel. It's extremely delightful. So so just like a little bit overview of the work that, like you mentioned, that we basically work. Like I'm a part of BETHAK. BETHAK is a grassroots organization that works on reproductive justice, and we do it in a very interactive way. So we basically engage the community through so we basically engage the community in a very informal way of discussion. So it's to create a safe space within different neighborhoods. So instead of the community coming to us, like we go to the communities and create those safe spaces within their neighborhoods. And when we talk about taboos, I think that in the South Asian region, um, taboos and myths are very closely related to the culture and traditions. Just like Mr. Kunde also mentioned that SRHR uh, in this region is very closely linked to cultural perceptions as well. So taboos are also often formed through the same chain of thought. So in the South Asian region, there's a huge culture of storytelling, that a lot of things are passed down the generations through storytelling, and that is how a lot of myths and taboos also come to are also passed down generations. And these also include myths related to SRHR and reproductive health, specifically menstrual health. So in different so they're basically different stories that maybe mother tell their daughters, or elder sisters tell their younger sisters, but they are basically they support this notion of shame around reproductive health. Basically, that's a huge part that's backed by the cultural perception of reproductive health as well. So what BETHAK basically does, like the work that I do with BETHAK, that in dismantling these taboos and addressing these myths. So we take a very interactive approach. And just like Ms. Sherry also mentioned, that now the communities have become very digitally connected. So I think with becoming digitally connected, there's another outcome of that. That is that now our attention span has also become shortened. So also to engage the communities in a way that is interactive and engaging, specifically when we're talking about adolescents. So when we're talking to adolescents and when we're addressing issues related to adolescents, we need to take a more interactive approach because they do have a shortened attention span. And that is what we're trying to do with Bethak as well, to create spaces that are more interactive, to add a element of creativity in it as well. For example, recently we did a community-based drive in which we called young people, and then we asked them to express their challenges to access menstrual health through art. And that was very interactive, and they were able to do it. Like, the results even surprised us. We thought that maybe the community would not approach it like we're thinking, but the results really shocked us because the youth interacted in it so wholeheartedly, because it's something that's very relevant to them. So I think that when we talk about taboos and dismantling them, we have to be aware of the age group that we're working with, and specifically with the adolescent and youth age group. We have to be aware that how their mind functions and what are the things that they can relate with, and what are the things that are very relevant to them. So a lot of times traditional means of advocacy don't work with that age group. So to make it innovative, you also have to ensure that you have people from the adolescent age group in your decision making and in the designing process of those advocacy campaigns and outreach campaigns. And I believe that only that way we can create more programs that target SRHR and are also effective and are also very relevant to that age group. And I also adding Nisa Kahania to this as well. So Nisa Kahania was also a very similar initiative with the same chain of thought, that now the young people approach information in a very different way. So there was one common narrative that we would hear in all of our grassroots sessions. That was whenever we would ask women, no matter what age group they belong to, no matter if they would be from a rural area or an urban area, whenever we would ask that, did you know what is menstruation when you got your first period? Most of the times the answer would be no. Like, no one told them. Their mothers did not tell them. The eldest sisters did not tell them. I'm also one of those people who did not know that what is menstruation, despite living in an urban area in an educated family. So then we had conversations with mothers and elderly women of the community that why is there this, why does this barrier exist? And the response was that now, even though there's an open access to information, like there's so much information on the internet, you can just go and access information regarding menstrual health, but it is not relevant to what they want to pass down to their younger generations. And it is also not that engaging to the younger girls that they can introduce them to the idea of menstruation in a healthy way and in a culturally appropriate way, and also through something that they can relate to. So that is where the idea of Nisa Kahania came in, again adapting to the storytelling tradition that is a part of the South Asian culture. So we adapted the storytelling approach to form this comic book regarding menstrual education. So it's a very colorful comic book where the characters look like South Asian girls, and there are stories that young girls from Pakistan can relate to. Like, they can see themselves in the characters, and they can their mothers can see themselves in the motherly characters, and it's something that can be easily passed down to girls. It's very colorful. It's very relevant. So that was the entire idea, to come up with something that the younger audience, the adolescent, have connect to and feel relevant, and also the elderly people who are the people who are doing this advocacy also feel comfortable to introduce to the younger audience. That was the entire idea of Nisa Kahania. And right now we have 3 different modules that we go and distribute in communities free of cost, so that young girls can have access to resources around menstrual education.
Thank you, Sila. We also do have a similar kind of initiative that we want to introduce in Nepal. I can see some of the Hamrabani champions were discussing in a group chat, oh, it's kind of sounds similar. So they are also excited, the entire team, to get to read about that book, which is more customized to Pakistan, because we also have a huge team in Pakistan who are trying to do community advocacy in SRHR. So maybe your curriculum would be much helpful to the team. And I know we do have Aisa from Baitak as a representative as well. So we'll be so excited to use that resources you already do have. Thank you for that. So we're going to move towards Novel now as a second round of the questions. So I want to, it's a very sensitive topic, and it's also a topic we're so passionate about, but I'm also being mindful of the time. And then I would like to ask speakers to narrow down their answer within 3 to 5 minutes, depending upon the responses. And I also would like to request all the participants, we do have a 89 participants. So I know you do have a different curiosities and questions. So feel free to write questions on a Zoom chat. Our team will, collect that and share that with me, and I will correspond that to the speaker as well. So going to Novel, thank you for sharing your takeaways and strategies on your earlier answer. And so secondly, we want to know about your initiative that you're engaged in through SRHR. So over to you.
Yeah, Prakriti, due to the time constraints, I think we would go and watch the video. You want to, can you please play it, or I have it as a backup?
I can do the screen share. Give me a second.
So this is just to connect from Dr. Beena and also Sila's suggestions and ideas on getting youth engaged. Okay, what does engaging youth would look like? So we want to share and speak to what we have done in Nepal. So, and we really want to expand it and improve it to other countries in more broader sense. So I would like to watch this video and then maybe reflect.
So the sound is.
Prakriti, can I try to share it from my end?
Okay, sure. Sure, Novel.
Yeah,
Stop
okay.
it.
Give me, yes, okay.
हाम्रो बहिनी नाम सुन्दैछु मेरो नामले जब फर्स्ट टाइम हाम्रो बहिनीमा म छु भन्दाखेरि बोथ द सेक्स होइन इन्फर्टिलिटी एकदमै कम होइन अहिलेको मेजर इस्युज इफ यु गो टु द सोसाइटी इफ यु मिट अप विथ रिलेटिभ्स
Yeah, so I don't want to say much. I think that this tells the story and the narrative and the strategy that we want to do through the uh, community engagement exchange uh, hub. Uh, we want to launch a similar initiative, or rather a movement in our region. So that is why we are here. So we know the issues, why the issues are, what these issues are, what the solutions are, and what role the youth can play and adolescents can play. And we want to create this as a platform where we can have a core group of youth, adolescents, as you saw in the video, and then empower them with the skill set, tools, and then they go out and spread the message like wildfire and make change in young people's lives. So that's very simple strategy that we want to do. And I think we can use this platform to create a movement around that. And I'm very happy that many stakeholders in the ecosystem are here, including the World Health Organization, UNFPA, family planning associations of our countries, and academia, universities, government organizations, and of course the community engagement exchange program, who has been behind the scene and motivating this whole hub. So with this support, I think we will be able to be very optimistic, and we can uh, replicate this in many other parts of our region. Over to you, Prakriti.
Thank you, Noble, and thank you for sharing the video of Hamra Bahini. So to all the participants who are not aware what is this is a Nepali term. That means our young sister. In this process, we select medical students who are in a medical school and train them about the sexual reproductive health and rights by 7 weeks of training. And after they get the training, they are named as Hamra Bahini champions, and they go to the community, do the community interventions nearby to their medical school. So that will, give us enough knowledge to and customize enough resources and all across the country. And then Noble was the mentor for this project, which is a part of Community Engagement Exchange project as well, and is a starting story how this we expanded it into a SRHR South and Central Asia Innovation Hub as well. We do have very proactive members for this. Thank you everyone for his role. Connecting this, Noble, you just gave me a right point to go to Dr. Beena. While doing the advocacy of Hamra Bahini as well, through the different champions, we've been to different community schools, and I do vividly remember, hi, Dr. Beena, if you are there, we do remember
Yes. Yeah.
there was a 14 years old boy asking us a question which was very difficult us to answer, bridging between the scientific truth and the cultural norms that is being followed in terms of menstruation. So how to address those kind of critical situations which is scientifically different, but which are not allowed to answer properly culturally during this kind of community intervention, and also during emergencies as well. So if you have any perspective towards that.
Yeah, the thing is like now the adolescent boys and all, they understand the situation of menstrual health and all, and still they cannot break this barrier. So those are the critical area where we really want to have a parents orientation also, awareness program among the parents also. It's not an easy task to in a one day or within a month we will bring a change in the community. We cannot do that because it's been since long. So yes, we have to ensure that they are safe. Even if they have some kind of a separately keeping they'll get a good food, and those kind of things that the 15 years boy can do. They can care after their mother, their sisters, youngsters, like they can be the support system for their mothers and all. So that time they need to ensure that their mothers or the sister who is having a menstruation is kept safe, kept in a safe place, and they are getting a proper food, water, and proper proper place to have a hygienic way of managing the menstruation. So those are the area. And here I'd like to connect Prakriti is the thing is like in the previous I didn't mention it like another critical area is the people with the disability, young and adolescent with the disability, and also the transgender community, which is really in a vulnerable group who can be get bullied during this and exploited during this humanitarian crisis situation. And that is also the area where we really need to think very critically, manage it in a proper way so that they will all have a safe space for each and everyone. So the like when we are talking about the menstruation in a young and adolescent, we have to think from the disability angle also, think from the transgender perspective also. So yes, we cannot bring the change at once. Slowly, we will be developing a good community, good safe community for every individuals. Here, not only one, all individuals needs to play their own role from their own side.
Thank you, Dr. Beena. Yeah, I just want to add a follow-up question to that. From your knowledge and perspective, are there any innovative approaches or technologies are being used in Nepal to improve the access and education in this field? Because it's still cultural taboos, and then there are already good practices.
Yes, there are many practices. I mean, the many in models we are big implementing, like a peer educator, developing a peer educator from the same community, transgender as a peer educator, people from disability as a peer educator. We are designing the program which involves the SRHR of not only the people with disability but their family also. And also we are making a WhatsApp group. We have a youth subcommittee committee in our working districts. We give them CSC training, and then they get mobilized into the in a school, out of school. They are giving a Fridays classes voluntarily. They are mobilizing themselves. So youth is the very much our the strength, our asset to bring the change, positive change in the community. So there are many approaches like those who can be reachable by the Facebook or the WhatsApp. There is a apps also, menstrual health apps. So many things we have been practicing, but those are limited to the some areas. So particularly for the country like ours, the more than virtual one, yeah, for some section of the adolescent, maybe the virtual one is quite reachable, but still we should not be neglecting the huge number of young adolescent. We have to go in person to person approach is really needed, because this is the really we need to invest a lot, and this one-time investment will bring a change in the community and change in the country itself.
Yes, thank you, Dr. Beena. That is also one of our concern, that how to reach to those adolescents who are not reachable through virtual medium, and then need to find an innovative solution to that. Also moving towards on a similar tone set, I want to go to Sila as well. There are some questions on the Zoom chat I can already see, and I would like to encourage participants to add more questions to there. I know you do have a different areas of questions and curiosity you really wanted to ask to panelists. I could see that from the registration form already. So there is one question which says, in a similar tone to the Beena, that Ward Mehmood, correct me if I pronounce your name incorrectly, asks that what role can education play in empowering adolescents to make informed decisions about their sexual and reproductive health in crisis situation? And if you can add this more about based on your experiences, and then teaching curriculum that is being taught in Pakistan based or in general South and Central Asia based. Over to you.
Yeah, thank you so much. And this is actually a very interesting question, and also a very important one, because I believe that the first part of taking in action is accepting and realizing that something is needed to be done. And to do that, we need education. And there are a lot of young individuals who don't even consider SRHR as their primary right. Like it is something that they have, it's their basic right that they should have access to SRHR products and services. So like just I'm going to back this question with an example of the work that Bethak did last year in the 2022 floods during the 2022 floods in Pakistan, because our campaign was around providing menstrual kits and menstrual health management awareness to the women that had been affected by the floods. And in that age group, there were also younger women who had gotten their first period during those floods, women who had been menstruating for some years, and also elderly women. So one major thing was that when we went up to them, they would not openly tell us that, okay, this is something that we need because this is our basic right. Like we had to we had to sit with those women and have those conversations, in-depth conversations. And then after 15, 20, 30 minutes, they would open up that, yes, these are challenges that we're facing regarding SRHR. And the prime reason that they would not immediately say that, okay, we need SRHR products and services is because they don't think that it is a basic right that they should have. And specifically the younger generation, because this entire conversation is so absent from the curriculums and the social spaces and educational spaces, that the youth doesn't even think that this is something that they need. So therefore they don't advocate for it. Like during times of crisis, if you consider SRHR as a prime basic right, therefore you will advocate for it. But because there is not enough awareness and education for especially the adolescent group to even consider that this as something important, they don't advocate for it. But um, during the floods, what Bethak, like during in our work, what we witnessed was that when we started giving these MHM talks and we started to talk with the younger girls, they actually became advocates in those very camps. Then they were like, okay, we will teach other women how to use pads, we will teach other women how to dispose them, because now we know. So that education that we were giving, that made such a huge impact, and that started that chain of reaction within that setting. So education definitely plays a huge role in not only empowering but also in be it ASRHR or like elderly women or prepubescent women even, to start advocating for it. The first step is to be aware about it and to be empowered enough to say that this is my basic right and I should have access to these products and services. Yes, over to you, Prakriti.
Yeah, thank you, Sila, for rightly mentioning and also sharing the success story. We had a similar experience as well on one of the community interventions. We're teaching how to use pads over panties, and then we asked the boys were like teenagers, and then they were doing it in no hesitations, and they were following all the steps, and that gave a comfort zone to young girls there as well. That it's a normal thing. It's like a bandaging to a wound or something like that. It's not a big deal. So that's I think a community level approach we can initiate and start and make this conversation very normalized. Thank you for sharing your part of story as well. So I want to go to the next question to Novel. This was a question from participants over the registration form. They wanted to know more about a global perspective and legal frameworks, but I think most of that area were addressed by our keynote speakers. But I would like to specifically highlight the question towards you is that how are different countries integrating SRHR education, including addressing LGBTIQA+ rights into the education and healthcare system? So feel free to answer it, and if there is if it doesn't fall on your radar, we do definitely understand as well. Over to you, Novel.
Thank you so much, Prakriti. Yes, I would like to address that question, as well as I want to address the question by Hasna Mujtaba, who was asking about how would we connect ASRH with WASH. So these are two interesting things. So one important aspect that we have to consider is that people and adolescents and youth and our communities have been discriminated or divided based on different lines. So some of those lines could be gender. It could be male, female, or based on the sexual identity. Another line, fault line that could divide the society could be on sexual orientation. And then we have our own other dividing lines such as religion, ethnicity, or whatever the divisions that, whether it's race, economy, or even digital divide, whether you have access to technology or not. So all these things are part of the broader divisions that we are having, but the consequences are the same irrespective of what the divisions are. The issue is, irrespective of those divisions across the countries, people have a right for sexual and reproductive health. It's not some kind of a blessing or something that the government or NGOs or other agencies have to grant people. It is not a beneficiary package, it is a right. So everybody, irrespective of those divisions, have a right to sexual and reproductive health. So I think the biggest change that should happen or has happened in countries like the USA or in other countries in the West, or even in some countries and parts of our region, is that pitching sexual and reproductive health as a right. So it is something that people have to demand our governments, health systems, and healthcare providers. So that is a major challenge that we have, and I think that is a strategic direction that ASRH work should move into. So it's not something negotiable. It's an unnegotiable right. And that is, I think, one of the major global developments that we have to focus on. Then addressing about the WASH and SRH rights. These are very connected, especially in disaster situations. You would have heard about the current crisis in the Gaza. I mean, think about the horrible stories we hear about food, not getting food for many days, about the continuous displacement, about being able to live, having to live in very restricted space. But we don't hear the stories about sexual and reproductive health. What about the menstruating women and girls in Gaza? We don't hear them, hear their stories. What about the contraceptive needs? What about the pregnant mothers who are close to delivery in those situations, those kind of disaster situations? So those are very important. And the water, sanitation, and hygiene can be promoting health. In the meantime, lack of water, sanitation, and hygiene can promote problems such as uh, uh, gender-based violence. Because if there's no lighting in a toilet, that can be the invitation for a rape. So simple thing as putting a light in the toilet or the washroom in the displacement shelter can prevent gender-based violence, and youth can take a role in that. Just speak out and say, our camp does not have a toilet with lighting, or the women having to travel to collect water can be increased exposure to gender-based violence. So provision of safe water at the camp setting can prevent gender-based violence. So there's a very close relationship between water, sanitation, and hygiene and sexual and reproductive health rights. And I really want to speak here. I think, Prakriti, you will tell, this is not the first and the last event. We will have, I think, 3 similar events, public events, but in all our countries, we will be having a series of youth engagement, empowerment programs, and all the youth who are here, you're all invited, and also please share the message to other youth networks. There are a lot of in-person virtual training opportunities that this program will have, including issues such as water sanitation and adolescent sexual and reproductive health as a right. Over to you, Prakriti.
Yes, thank you, Novel. I was about to add that section as well. So we can already see 70 plus participants still here. So we'll share our social media links as well. And then we have representative in Pakistan, Kazakhstan, Bangladesh, Sri Lanka, and Nepal. So you can directly reach out to our social media channel. And if you want to be a part of these kind of initiatives in these countries, you're always welcome. And if you also want to take a lead, we would like to welcome the leaders because we need more and more youths into this advocacy. So I can talk on behalf of Nepal. We'll have an in-person event similar in different thematic area around the end of the April as well. So feel free to write to me directly. Or feel free to write on our social media handles as well. So moving forward, there is also a question from Marisa, which is, I think, more focused towards the situation in Nepal. So I'd like to address that question to Dr. Beena. So hi, Dr. Beena. So Mary has asked that, given the emphasis on local youth advocacy, are there specific policy changes or recommendations you believe the Nepalese government should consider adapting to better support and empower adolescents, especially in the realm of sexual reproductive health in crisis situations? So more like successful policies, or are there any recommendation ongoing through the Nepal's government in regards to crisis? Dr. Beena, over to you.
Well, from the policy perspective, I think we are the very much pretty good country where we have a really good progressive policies in our hand. The implementation is the challenge everywhere, I guess. And from the youth perspective also, we have our government has given a very comparatively, I think we are pretty much in a good policy side. So only thing is like the sexuality education is not being taken that seriously, and still the government, the policymakers and leaders, they do not give importance to, or they also need, I think, more than the adolescent. We need to do more education or advocacy to the leaders and the policymakers to ensure that this will be not a taboo subject. It is a much needed subject, SRHR. So I think from the policy aspect, we are in pretty much good hand in Nepal.
Thank you. Yeah, thank you, Dr. Beena. So if the participant would like to get to know about those policy, maybe we can help you and facilitate at sending those, which is easily accessible through the website and portals of Nepal Health Ministry and Population. I think it's similar to other parts of the country, world, South Asian world as well. So I can see the time. We're towards the end of this program. So I'd like to ask all three speakers to give their closing remarks from their side, any recommendations or any notes to all the young youths who are still here with us, almost more than 2 hours plus, means they're really curious about this and want to work on this. So over to all three speakers, your closing remarks, and then we'll go. We also have a poetry actually from a group of Hamra Baini champions. They just sent it to me on email. So I was looking if we have enough time. The poetry is of 2 minutes, and I would love to play that as well. So starting maybe from Novel, in a minute, your closing remarks, and then Beena and Sila. Thank you. You are on mute, Novel.
Yeah, sorry. So I want to crystallize our learnings into three things, what we can do. Number one is youth can be engaged in a culturally appropriate peer education that we are already doing. If, Family Planning Association Nepal is doing. We heard stories from Sila about her work, and then we watched Hamra Bahini work. So many other programs are there. I know recently Family Planning Association of Sri Lanka was doing similar work on comprehensive sexuality education along with UNFPA and the government. So we have to continue those things, engage youth in culturally appropriate peer education. That's number one. Number two would be we have to make youth resilient as individuals, as well as communities. So we have to invest in making them stronger, making them resilient, making them more empowered, so that they can protect themselves, they can serve the others, as well as function as a community. The whole hub is about creating a community of practice. So I think that is a really important second message of becoming more resilient and as individuals, as communities. And third one would be to speak up through youth-led advocacy and digital engagement. Um, I think there's a big revolution happening right now with artificial intelligence. Uh, the knowledge is being kind of liberalized. The knowledge that was stuck inside libraries or inside schools are coming out. So how can we benefit the youth from the global south so that they can reach the benefits of new technologies, and how they can make the engagement digital? Now we are meeting from 4 different, or rather 6 different countries, and then
We are more, no, we are more than that.
more than
We have a participant from Egypt. I think somewhere in the African other countries as well. So I need to still count it. Maybe 7, 8 plus countries here.
So
Okay.
just imagine 7 or 8 country conference for 100 participants would not have been possible if we didn't have digital engagement. So now youth can be, have more opportunities. We have a lot of benefits from technology. So there's more space for youth to speak up through youth-led advocacy and digital engagement. But the issue is, only a very limited number of youth and adolescents have access to those technologies, but they can easily be made available. We have mobile phones, but do we use mobile phones as youth to advocacy? That is a question. So these are some things. So in summary, engage in culturally appropriate peer education, become resilient as individuals and communities, and speak up through youth-led advocacy and digital engagement. Those would be my key messages.
Yeah, thank you. Thank you, Dr. Noble. I was almost about to say that, timer, but you made it within the time frame. Thank you. Over to you, Sila. Your closing remarks within a minute. Okay.
Yeah, I think I'm just gonna second everything that Mr. Noel said, especially regarding youth building that resilience, because at this point we have to demand for SRHR as our right. Like no one else is going to do it for us. We have to occupy those spaces. We have to make space for ourselves. We have to be resilient and ask for our rights. So that's my takeaway.
Thank you, Sila. Dr. Veena, over to you. Hello. Okay.
Okay, yeah. So mine is like to everyone here present, what I want to say is we need to start talking about the SRHR from our home. We have to involve our parents. We have to involve our brothers and sisters in this one so that we can easily speak up on the SRHR, so that you can talk with your neighbors, you talk with your colleagues, you talk with your community, speak up. Don't just keep the knowledge or the information that you gain only up to you. Let's spread the information, somehow make it like one of our colleagues said, from the storytelling. Sometimes we can have a perspective, we can start the conversation from the perspective of other people's perspective also. So let's start conversation around the SRHR within the home, from through our brothers, because male engagement is very necessary. Let's, even those males who participants are here, talk about your sister's problems, anything, just start speaking about this. So that is the only thing I want to request everyone. Let's talk about the SRHR from our home. Thank you.
Thank you, Dr. Veena. And then I will like to reuse the phrase from one of our keynote speakers, Sadie, like leaving no one behind on agenda for advocacy should be the mantra for all of us to start talking from outside. Thank you all amazing panelists for your valuable time, insights, and your continuous dedication to our sexual reproductive health and rights in disaster and in different contexts. So on upcoming quarterly events, we will talk about in climate change, in mental health, in so many areas, or in different things. So for that, we'll be sharing shortly our social media handles QR code as well. And as I promised earlier, we're on a time. So if you still want to stay here, I can create a breakout rooms and where all of you can talk, interact within yourselves, share your LinkedIn account or anything. And then also, there's also a WhatsApp group chat we just created to share the quarterly event updates. We know that the WhatsApp group chat, you have a full freedom to join it by yourself on your discrete. And then we'll keep on sharing our information details. And if you have anything that you also want to address or share, or if you think there are any recommendations for the other speakers you would like to recommend for other quarterly event, feel free to share that. Having said that, I have a poem I received from our participants. I think it's a very short poem, and I would like to play that poem here. If it is visible, can someone give a thumbs up to me and I'll play? Okay.
In tremors dance a world upheaved, styling plea for the right concept. Amidst the quark of fragile plea, the need echoes its all below. Bound by chaos, the voices rise, seeking right beneath the fractured skies. Health and choice goes hand on hand, even in the fiascos, let the freedom stand.
In aftermaths, a chord resounds. This is where hope rebounds through scattered knobs, a pathway face, empowering lives in the emergency embrace. And missing the quake's trembling embrace, we stand strong in grace. In shouts, our voices raise. Health and rights, a sheer sunrise.
Foundations shaking, it we stand. Empathy extends a helping hand. Resilience blooms in the aftershock. Youth a cornerstone and unwavering rock. Amid the shambles, hope persists. Choices respected, our rights exist. Following the tremors, uncertain dance, resilience of steadfast advance.
In the Brahmins, stories unfold of care and choices, brave and bold. Empowering the lives in the difficult night, UFI a beacon of guiding light. So let the awareness rise from the ground. SRHR echoes with a profound sound. In every emergencies that we face, right and health, always a steady embrace. Thank you.
Thank you very much, the team, for creating this video and for actively participating. So to give their background, all of them are SRHR champions, medical students who were trained before, and then they have been to different parts of the country, ranging from 800 kilometers away from the capital city to different provinces, and they really did amazing job. Sometimes that inspired us as an organizer to push this agenda more and more. Thank you for your active participation. And we would love to hear if you have anything, such a poetry or anything you want to share on upcoming quarterly event. We'd like to welcome your content. Just share us, send us on our email. So this is the Facebook and then Instagram link. Please connect it with us. And thank you for all the keynote speakers, Avni, Seri, Kunle, our panelist speaker, Sila, Novil, and Bina, for your amazing presence, for working throughout us and helping us to build this event to make it more successful. Again, thanking to US Department of State for making this dream come true, because we started something small from Nepal, and then we got an amazing, interesting team within the community of Community Engagement Exchange. Now we're a team of 9 members, and then now we're going to South and Central Asia. Who knows, with this continuous work and dedication with this team of more than hundreds attended today, we can take this agenda more globally with the presence of all the amazing experts as well. So feel free to connect with us with Facebook and Instagram. And I have also sent in the group chat feedback link, which is also on the screen. Please scan it and then write the feedback for us, because our right feedback and then also good commitments will help us to improve and to feel confidence about our upcoming events as well. So please, it is very essential for us to get feedback from all of you. So I'll leave it for a few minutes for feedback and for you all to get connected with us in social media. For now, it's 7:20 p.m. right at the time. So I would like to officially close this first quarterly event. Thank you everyone for your active participation, for making this such a successful event. We'll come ahead in a couple of months with a different thematic area focusing on SRHR for second quarterly event. And also we will welcome you on any of the local regional events we'll be doing. I think something is happening soon in Sri Lanka within January, February. Something is happening in March in Pakistan. I think a conversation is around in Kazakhstan to do a local event in April. I think similar time in Nepal. So things are happening around in context of SRHR. So we will welcome expertise, mentorship, participation, guidance, all kind of support in all ways possible. So give me a thumbs up or a heart reaction if you are still up to our breakout rooms. Our technical team will help you to create a breakout room. Thank you, Dr. Veena, for your presence. So I would like to say we are officially done with the first quarterly event. Thank you, all of you. Now we can create a breakout room for a couple of minutes for all of our participants. And I'll ask the technical team to stop recording with the thank you note to the technical team as well. To all of our founders and members and from the team of IDEX as well. Thank you.